Good night, everyone. My name is Dr. Ramrup, and today I'll be presenting on the functional neuroanatomy of the brainstem. So, why does the brainstem matter? It's clinically important because it integrates the fundamental systems required for life. So, consciousness via the reticular activating system, respiratory rhythm generation, and cardiovascular tone. It also serves as the central conduit for every major ascending and descending pathway, which is why focal lesions produce highly patterned deficits. In addition, it contains the nuclei of cranial nerves 3 through 12 and coordinates several complex reflexes, such as swallowing, coughing, and vomiting. Because the anatomy is compact, small lesions can generate distinct clinical patterns, making the brainstem a rewarding region for precise neurological localization. So that leads us to the learning outcomes of this session. So the goals are one, to describe the structural organization of the midbrain pons and medulla of the brainstem, identify major tracts and cranial nerve nuclei within each level, explain how anatomical structures relate to function, localize common brainstem lesions based on clinical findings, and then apply functional anatomy to neurosurgical approaches. So just an overview of the brainstem architecture. It helps to start with this layout because it's remarkably consistent from the medulla up to the midbrain. There are three major divisions, the medulla, pons, and midbrain. Sorry, medulla, pons, and midbrain, yeah. Each has its own profile, but they all follow the same core plan. The first principle is a ventral dorsal organization. The ventral or basilar portion is predominantly motor. This is where you find large descending systems, particularly the corticospinal and corticobulbar tracts. That's why ventral lesions often present with motor deficits out of proportion to sensory involvement. The tegmentum forms the central core of the brainstem, and it's the functional engine room in a sense, containing cranial nerve nuclei, ascending sensory pathways, autonomic centers, and reticular formation. The dorsal aspect houses structures related to the ventricular system, including the floor of the fourth ventricle in the pons and upper medulla, and the tectum in the midbrain. The second principle, cranial nerve emergence, occurs in organized levels. So in the midbrain, you have cranial nerves 3 and 4, and the pons gives rise to 5 through 8, and then the medulla carries 9, 10, 11, and 12. And the final point is that position will predict function. So let's look at the cross-sectional layout principles. So each axial slice follows a three-compartment organization. But what's important here is not just the ventral dorsal concept itself, it's how the content within each compartment changes as you move up the brainstem. For example, in the medulla, the hallmark structures on cross-section are the pyramids ventrally, the olives laterally, and the nucleus, such as the nucleus ambiguus, centrally. These features immediately tell you that you're in the medulla. In the pons, the ventral compartment becomes dominated by the pontine nuclei and the transverse pontocerebellar fibers, giving the pons its recognizable striped appearance on MRI. The tegmentum at this level contains distinctive structures such as the fascia colliculus, abducens nerve, and the MLF, or your medial longitudinal fasciculus, which helps explain why the pons is the key site for gaze pathway disorders. In the midbrain, the ventral region forms the cerebral peduncles, while the central tegmentum houses the red nucleus and the substantia nigra. Dorsally, the appearance of the superior and inferior colliculi immediately identifies this as the midbrain. So the focus again is recognizing while the compartments do stay the same, their contents define the level. So the functional organization of the brainstem only makes sense if you pair it with its vascular supply. So the brainstem is perfused almost entirely by the vertebral basilar system, and the vascular branching pattern directly explains the classic brainstem syndromes. So there are three major categories of penetrating vessels. One, the paramedian branches. These arise directly from the vertebral or basilar arteries that enter the brainstem at the midline. Two, the short circumferential branches. They sweep laterally into the tegmentum and supply cranial nerve nuclei, sensory pathways, and reticular formation. And three, the long circumferential branches that reach the more dorsal and dorsal lateral regions, often extending into the cerebellar structures. So when broken down by level, each segment has characteristic arterial contributors. So in the medulla, the key vessels will be a vertebral artery, your pica, and the anterior spinal artery. The pons is supplied by the paramedian branches of the basilar artery, the short circumferential branches, and the ica laterally. And then in the midbrain, it receives its blood supply mainly from PCA perforators and superior cerebellar artery. So looking at the ascending pathways as the course of the brainstem, first they have the dorsal column medial lemniscus system. This carries fine touch, vibration, and proprioception. One of the key features here is that decussation occurs in the lower medulla for forming your medial lemniscus. As you ascend, the medial lemniscus changes orientation. So it's vertical in the medulla, it begins to rotate in the pons, and it becomes more horizontal in the midbrain. So when a patient has a selective loss of proprioception with sparing of pain and temperature, and the MRI shows a midline lesion, you can immediately consider medial lemniscal involvement. Secondly, you have your spinal thalamic tract. This has already crossed at the spinal level before entering the brainstem. It travels laterally throughout the medulla, pons, and midbrain. And then third, you have your spinocerebellar pathways. So these carry unconscious proprioception, and they enter the cerebellum via the inferior and superior cerebellar peduncles. Next, we move on to the descending pathways, which is responsible for voluntary movement, motor control, posture, and tone. And the emphasis here is on positional anatomy and clinical consequence, because that's what matters when we're trying to localize lesions. So one, the corticospinal tract, responsible for voluntary limb movement, travels ventrally throughout the entire brainstem. In the midbrain, it's highly compact within the cerebral peduncles, and as it enters the pons, it temporarily becomes more dispersed between pontine nuclei before eventually reconsolidating as the pyramids in the medulla, where it eventually decussates. The corticobulbar tract runs close to the corticospinal fibers and provides input to cranial nerve nuclei. Beyond these primary tracts, the ascending brainstem motor systems play important modulatory roles as well too. So the rubrospinal tract, originating from the red nucleus, decussates early in the midbrain and carries a flexor bias. The reticulospinal tracts regulate your posture, your tone, gait initiation, and autonomic reflexes. And then the vestibulospinal tracts support balance and extensor tone, integrating closely with the cerebellar and ocular reflex centers. So the reticular formation now, it's not a single structure. It's more of a distributed network that runs through the entire core of the brainstem. So the rostro-reticular formation, centered in the upper pons and midbrain, gives rise to your ascending reticular activating system, or your ARAS. This system projects the thalamus and cortex, and it's fundamental for consciousness and arousal. If you have damage here, even with relatively small lesions, that can produce reduced arousal states from hypersomnolence even to coma. This explains why midbrain tegmental injury often leads to disproportionately severe alterations in consciousness compared with a similar sized lesion elsewhere. The caudal reticular formation is primarily in the lower pons and the medulla, integrates autonomic and motor functions. And this region houses the neuronal groups responsible for respiratory rhythm generation, the cardiovascular reflexes, and coordination of swallowing and coughing. Because the nuclei are interlinked, lesions in this region can produce combined deficits, such as autonomic instability with impaired airway protection. Within this system, several nuclei have very distinct functional roles. So one, you have your RAF nuclei, which provides serotonergic outputs, influencing pain modulation and mood regulation. And their projections to the dorsal horn explain endogenous analgesic mechanisms. Then you have your locus coeruleus, which is the primary source of noradrenaline, and that plays a major role in vigilance and stress response and your sleep-wake regulation. And then you have your pedunculo-pontine nucleus positioned at your mesencephalic pontine junction. That contributes to gait initiation and it modulates REM sleep. And this nucleus has actually become increasingly relevant in movement disorder research and deep brain stimulation. So reticular formation involvement is suggested when a patient presents with disorders of consciousness, autonomic dysregulation, or deficits that do not map cleanly to a single cranial nerve nuclei or tracts. So when it comes to cranial nerve nuclei, before looking at the cranial nerve nuclei level by level, it's important to understand the general organization plan, because the pattern, again, applies throughout the brainstem and explains why specific cranial nerve deficits cluster together. So cranial nerve nuclei are arranged in longitudinal columns, as you can see in the diagram here. And this arrangement is actually based on embryologic development. So structures derived from your basal plate end up medial and become your motor nuclei. Structures derived from the alar plate are displaced laterally and form your sensory nuclei. So this gives us four major functional columns. One, your somatic motor nuclei, which are the most medial, including nuclei like 3, 4, 6, and 12. And their medial position explains why medial brainstem lesions often present with isolated somatic motor cranial nerve palsies combined with corticospinal tract signs. Then you have your branchial motor nuclei, derived from your pharyngeal arc musculature. They sit just lateral to the somatic motor column, and these include nuclei such as your facial, trigeminal motor, and your nucleus ambiguus. And their clustering explains why lesions affecting the lateral tegmentum can produce combined deficits involving facial expression, mastication, and swallowing. Then you have your parasympathetic nuclei, such as your Edinger-Westphal nucleus. superior and inferior salivatory nuclei, and the dorsal motor nucleus of the vagus, which occupy a position between the motor and sensory columns. Their intermediate location makes them susceptible to tegmental lesions that spare the more medial pathways. And then 4, you have your sensory nuclei that lie the most lateral, including your trigeminal sensory nucleus, your vestibular and your cochlear nuclei, and the nucleus of the solitary tract. Because of the lateral position, lateral medullary and lateral pontine lesions reliably produce sensory deficits, especially involving pain, temperature, and special sensory modalities such as hearing and balance. And this columnar organization is consistent throughout the entire brainstem. And this is just a bit of a one-depth look of the diagram itself. So you can see the sensory more lateral and the medial ones more medial. And this correlates with your embryologic development, how it develops embryologically. So moving on to the midbrain, the nuclei of the midbrain, pons the medulla. The midbrain contains a compact but functionally diverse set of nuclei. So we're going to group these structures by their roles and then link them to typical clinical patterns later. So starting with the cranial nerve nuclei, you have your oculomotor nucleus, heading a westphal nucleus, trochlear nucleus, and then motor modulatory centers such as your red nucleus, substantia nigra, pedunculo-pontine nucleus, and then your periaqueductal gray. So this image better shows it as opposed to just reading it. So starting with the cranial nerve nuclei, the oculomotor nucleus provides somatic motor innervation to most extraocular muscle. It lies ventral to the periaqueductal gray, and it's tightly integrated with the gaze centers. Just dorsal and medial to it is the Edinger-Westphal nucleus, the parasympathetic component of cranial nerve 3, and its fibers travel superficially, which explains why you get pupillary abnormalities that often precede extraocular movement deficits in compressive lesions, such as having a posterior communicating artery aneurysm. The trochlear nucleus sits at the level of the inferior colliculus, and it's unique for 2 reasons. Its fibers decussate completely, and it exits the brainstem dorsally, which explains contralateral superior oblique palsy with nucleus-level lesions. Motor and modulatory centers occupy the central midbrain segmentum. The red nucleus integrates cerebellar input and projects via the rubrospinal tract, contributing to motor coordination. Lesions involving the red nucleus typically produce contralateral ataxia and tremors, which are seen in syndromes like Benedict syndrome. The substantia nigra contains dopaminergic neurons projecting to the basal ganglia, and degeneration here underlies Parkinson's disease, and midbrain pathology involving this region can also produce akinetic rigid syndromes. Your pedunculo-pontine nucleus sits at the mesencephalic pontine junction, and that plays a role in gait initiation, postural stability, and sleep-wake regulation. Finally, you have your periaqueductal gray surrounding the cerebral aqueduct, which participates in pain modulation, particularly the descending analgesic pathways. Next, we move on to the pontine nuclei, which involve your cranial nerve, your motor and sensory nuclei of your trigeminal, abducens, facial, vestibular, and cochlear, and then your horizontal gaze circuitry, as well as some other key pontine structures, which you can see in this image here. So the pons is the most clinically recognizable region of the brainstem because its nuclei and pathways create characteristic patterns when injured. So starting with the cranial nerve nuclei, the trigeminal nuclei provide both motor supply to the muscles of mastication and sensory input from the face. Clinically, trigeminal involvement in the pontine lesions will give early clues like corneal reflex loss, facial numbness, or difficulty chewing. The abducens nucleus is a key landmark. Its clinical relevance stems from the fact that it's not just the nucleus for lateral rectus, it is the horizontal gaze center as well. The facial nucleus sits laterally. They wrap around the abducens nucleus before exiting the brainstem. This looping will create your facial colliculus, which is a surface landmark seen on the floor of the fourth ventricle. This anatomical relationship explains why lesions affecting the facial colliculus can produce combined facial paralysis as well as gait abnormalities at the same time. You have your vestibular and cochlear nuclei, which lie more dorsolaterally and are involved in balance and auditory processing. And these nuclei are typically affected in lateral pontine lesions, which explain your vertigo, nystagmus, and hearing loss patterns that you get with it. The paramedian pontine reticular formation, or the PPRF, initiates horizontal saccades. So damage here causes impaired fast eye movements toward the side of the lesion. The MLF, running longitudinally, links to the abducens nerve to the contralateral oculomotor nucleus. A lesion here will produce intranuclear ophthalmoplegia, which is impaired adduction on the affected side with nystagmus of the abducting eye. Other important pontine structures include your pontine nuclei and your transverse pontocerebellar fibers, which form the communication bridge between the cortex and the cerebellum, which is why pontine lesions can often present with contralateral ataxia even when cerebellar nuclei are spared. Next, we move on to the medullary nuclei, which involve your somatic motor nuclei, your branchial motor and parasympathetic, sensory and visceral integration, as well as important autonomic and respiratory centers, which you can see here, most of them here. So starting with the somatic motor nuclei, the hypoglossal nucleus sits paramedian and contributes to tongue movements. A lesion here at this level will cause ipsilateral tongue deviation due to lower motor neuron weakness, which is a reliable sign in medial medullary pathology. The cranial portion of the spinal accessory nucleus contributes fibers to the vagus nerve and nucleus ambiguous pathways, which explains why some lesions produce combined vocal and swallowing deficits. And the nucleus ambiguous is a key branchial motor nucleus. So it supplies motor fibers to the muscle of the soft palate, the pharynx, and larynx through cranial nerves 9, 10, and 11. And this single nucleus could explain why you'll get dysphagia, dysphonia, nasal regurgitation, and impaired gag reflexes in lateral medullary lesions. Just dorsal to that sits the dorsal motor nucleus of the vagus, the major parasympathetic output to thoracic and abdominal organs. So this is important for modulation of heart rate, gut motility, bronchial tone, which all pass through here, which is why if you have any sort of medullary autonomic instability, it's quite clinically significant. The sensory and visceral integrative centers are also equally important. So the NTS, or the nucleus of the solitary tract, integrates taste, baroreceptor, and chemoreceptor inputs. So disruption here will cause loss of taste, but also impaired autonomic reflexes and cardiovascular dysregulation. The spinal trigeminal nucleus, positioned laterally, carries pain and temperature sensation from the face, which explains classic ipsilateral facial sensory loss in lateral medullary infarctions. And you have the inferior vestibular nuclei, which contribute to balance and ocular reflexes. Their involvement will produce vertigo and nystagmus patterns characteristic of dorsolateral medullary lesions. Finally, the medulla contains essential autonomic and respiratory rhythm centers. So the pre-Botzinger complex located in your ventrolateral medulla generates respiratory rhythm, and nearby networks will coordinate swallowing, coughing, and vomiting. So any damage to these areas explain life-threatening respiratory irregularities in high medullary pathology, if present. So looking at the autonomic centers of the brain, cardiovascular regulation begins with the nucleus tractus solitarius. So that's the NTS. The NTS receives baroreceptor and chemoreceptor input from the glossopharyngeal and the vagus nerve. So it integrates this information and modulates sympathetic and parasympathetic outputs via your ventrolateral medulla. Damage here will produce impaired autonomic reflexes, so that will be like poor heart rate and unstable blood pressure regulation. You also have the RVLM, or your rostral ventrolateral medulla, which sets your baseline sympathetic tone, and this region maintains resting blood pressure through tonic activity. If compromised, patients can exhibit profound hypotension, unresponsive to typical vasopressor dosing. Then you have your respiratory control centers, which form a coordinated network. So again, the pre-Botzinger complex, again, located in the ventrolateral medulla, is the primary generator of respiratory rhythm. And then you have your dorsal and ventral respiratory groups. So the dorsal respiratory group in the nucleus of the solitary tract coordinates inspiration, while ventral respiratory group contributes to forced expiration and accessory muscle recruitment. So lesions affecting these centers will produce irregular or agonal breathing patterns, as well as central hypoventilation. You also have reflex integration centers that sit within the medulla. So swallowing, cough, and vomiting centers here are tightly interconnected, and they rely on the nucleus ambiguous, the NTS, and adjacent pattern generations. And any sort of disruption here will lead to impaired airway protection. The brainstem is also important for eye movement circuits. So starting with the horizontal gaze, that's coordinated at the level of the pons. So the PPRF initiates horizontal saccades. So damage here leads to loss of fast saccadic movements towards the side of the lesion, while pursuits and vestibular stimuli still may partially be preserved. Immediately adjacent is the abducens nucleus, which has a dual role. So one, it drives the lateral rectus on the same side, and it sends interneurons via the medial longitudinal fasciculus to the contralateral oculomotor nucleus to activate the medial rectus. Because this nucleus coordinates both eyes simultaneously, a lesion here produces a horizontal gaze palsy and not just a abduction deficit. As said before, a lesion at the MLF will result in intranuclear ophthalmoplegia, which is impaired adduction on attempted horizontal gaze, with those dissociated nystagmus of the abducting eye. The vertical gaze pathways, in contrast, are located in the midbrain. So the RI, or the rostral interstitial medial longitudinal fasciculus, generates vertical saccades, while the interstitial nucleus of Cajal serves as the neural integrator, stabilizing vertical and torsional eye position. Fibers responsible for upgaze cross at the posterior commissure, which is why dorsal midbrain regions, particularly from pineal masses or hydrocephalus, classically produce a upward gaze palsy. Vestibular ocular integration begins in the vestibular nuclei, and that projects through the MLF to the ocular motor nuclei, which explains your nystagmus patterns, ocular tilt reactions, and head impulse test findings in both pontine and medullary lesions. So there's also important cerebellar connections with the brainstem. So the inferior cerebellar peduncle carries input into the cerebellum from the spinal cord and the medulla. And this includes the dorsal spinocerebellar fibers for unconscious proprioception and key vestibular projections. Because these fibers remain predominantly ipsilateral, lesions involving the ICP typically produce ipsilateral limb ataxia, not weakness. The middle cerebellar peduncle, is the largest, and that carries fibers from the pontine nuclei. These fibers originate from the cortical inputs, they cross the midline in the pons, and then enter the cerebellum as pontocerebellar fibers. Damage to the middle cerebellar peduncle disrupts cortical cerebellar integration, which can often produce limb ataxia and dysmetria, but spares cranial nerve function unless the lesion extends medially. The superior cerebellar peduncle, that's the major output pathway from the cerebellum. Its fibers project to the red nucleus and ultimately then the thalamus. Crucially, the superior cerebellar peduncle decussates in the midbrain, which has important clinical implications. So lesions below the decussation will cause an ipsilateral ataxia, while lesions above the decussation will cause contralateral ataxia. So that can distinguish pontine versus midbrain involvement if you have ataxia present. The vestibulocerebellar system integrates through the vestibular nuclei and the furunculonodular lobe. So this circuitry coordinates balance and eye movements, including the vestibular ocular reflex. Lesions here, if you have them present, would produce nystagmus, unsteady gait, and difficulty with rapid head movements. So the brainstem also plays a central role in descending modulation of pain. And this pathway is particularly important because it explains endogenous analgesia, or the mechanism of opioids, and changes in pain perception following brainstem injury. So the starting point here would be the periaqueductal gray, which is located in the midbrain. This receives input from the cortical regions involved in attention and emotion, as well as the hypothalamus and amygdala. So its function is to integrate these signals and determine when pain should be amplified or suppressed, typically suppressing nociception during threat, stress, or any goal-directed behavior. From the periaqueductal gray, signals descend to the ventral medial medulla, which acts as a regulatory relay station. And it contains two key cell types, so your on cells and your off cells. So your on cells will facilitate nociceptive transmission, while your off cells inhibit it. So balance between these populations set the overall tone for pain processing. The fibers then project to the raphe magnus, the primary serotonergic nucleus involved in descending inhibition. So these projections descend in the dorsolateral funiculus of the spinal cord, and they terminate in the dorsal horn. Here, after they terminate in the dorsal horn, they activate interneurons that release inhibitory neurotransmitters such as serotonin and enkephalins, which reduces dorsal horn neuron sensitivity. And functionally, this will provide your endogenous analgesia, so your ability to suppress pain during stress and focused behavior. And it also explains why opioids act strongly at the level of the periaqueductal gray. Why lesions here can produce altered pain thresholds, and why certain neurosurgical or vascular lesions can paradoxically present with either heightened or diminished pain responses. So clinically, dysfunction in this system can present as unexplained changes in pain sensitivity or failure of typical nociceptive patterns or exaggerated responses to normally mild stimuli. So the rule of fours localization framework. So this is used for brainstem localization, and it reduces the entire brainstem to a small number of predictable structures, and it's helpful to localize the deficit without imaging. So there are four medial structures, four lateral structures to remember, and four cranial nerve levels. So the four medial structures to remember would be one, the motor pathway, specifically your corticospinal tract, which, a medial lesion will produce contralateral limb weakness as a result. The medial lemniscus carrying proprioception and vibration. Involvement here will cause contralateral loss of fine touch and position sense. The medial longitudinal fasciculus, if here, you can get internuclear ophthalmoplegia. Then the motor cranial nerve nuclei, which lie medially for cranial nerves 3, 4, 6, and 12, and damages here can produce ipsilateral cranial nerve palsies. Then you have your lateral structures, which are equally as consistent. So your spinothalamic tract gives contralateral pain and temperature loss. The spinocerebellar pathways give ipsilateral limb ataxia. The sensory nucleus of cranial nerve 5, responsible for ipsilateral facial pain and temperature sensation, is important in lateral pontine and medullary lesions. And then the sympathetic pathway, whose involvement produces ipsilateral corner syndrome. Then you have to remember the four levels of cranial nerve emergence to determine whether the lesion is in the midbrain, pons, or medulla. So 3 and 4 are in the midbrain, 5 to 8 are in the pons, and then 9 to 12 are in the medulla. So when you combine all of these, it allows for a rapid localization essentially before you can get an MRI done. So with all that being said, when it comes to localizing, let's look at the different lesions that you can get now and how they present. So they have a couple here that I wanted to touch on. So you have your midbrain syndromes, your pontine syndromes, and then your medullary syndromes. So let's start with the midbrain syndromes. So the first one would be Weber syndrome, which is a classic example of ventromedial midbrain lesions. So this lesion will affect two structures. So the fascicles of cranial nerve 3 and the cerebral peduncle, which contains your corticospinal and your corticobulbar tracts. So when this happens, on the side of the lesion, the patient will develop a complete oculomotor palsy. That means you get a ptosis, the eye deviating down and out, and often a dilated pupil because the parasympathetic fibers are superficial and vulnerable. The presence of any pupillary involvement is an important clue, suggesting a nuclear or fascicular lesion rather than just a microvascular palsy. And then contralaterally, there's a hemiparesis due to involvement of the corticospinal tract. Depending on how much of the corticobulbar tract is affected, you can get facial weakness, also seen, although it can typically be less pronounced. From a vascular standpoint, this pattern reflects involvement of the paramedian branches of the posterior cerebral artery or basilar tip perforators. And again, the key localization feature here would be a single ipsilateral cranial nerve 3 palsy with contralateral motor weakness. Then there's Benedict syndrome. So as with Weber's, ipsilateral cranial nerve 3 involvement will produce ptosis, ocular deviation, and often pupillary dilation. This will tell you that the lesion is in the midbrain. So what distinguishes Benedict syndrome is the effect on the red nucleus and neighboring cerebellothalamic fibers. So the red nucleus integrates cerebellar output and participates in motor coordination. So a lesion here would produce contralateral ataxia, dysmetria, and often a coarse or rubral tremor. So this cerebellar type presentation is a hallmark of Benedict's sign and helps differentiate it from Weber's. So depending on the extent of the lesion, the medial lemniscus can also be involved, which can produce a contralateral loss of vibration and proprioception, though it's not always essential for a diagnosis. And then from a vascular standpoint here, the syndrome most commonly arises from infarction in the paramedian branches of posterior cerebral artery. So again, the localization principle to look at here is oculomotor palsy, which will tell you that the lesion is in the midbrain, and then a contralateral ataxia or tremor, which tells you that the red nucleus is involved. And when these occur together, the lesion must sit in the midbrain tegmentum and not, the ventral peduncle. Then there's Claude syndrome. So the Claude syndrome is another oculomotor syndrome involving syndrome, but the distinguishing feature is the involvement of the superior cerebellar peduncle and not the red nucleus instead. So this lesion sits in the dorsal tegmentum of the midbrain. So it affects the fascicles of cranial nerve 3 and the diffusating fibers of the superior cerebellar peduncle, which carries your cerebellar output towards the thalamus and motor cortex. So clinically, the patient develops an ipsilateral cranial nerve 3 palsy, identical to that seen in Weber or Benedict. The oculomotor findings don't differentiate in these syndromes. So the difference would be contralateral limb ataxia. So Because the superior cerebellar fibers are involved, peduncle fibers are involved, the presentation resembles, sorry, a cerebellar output rather than a red nucleus lesion. So ataxia is prominent, but a tremor is typically less pronounced than in Benedict syndrome, where the red nucleus involvement drives that sort of rural tremor. The vascular territory is again the paramedian branches of the posterior cerebral artery, though the lesion is slightly more dorsal than in the other midbrain syndromes. And the localization principle here would be cranial nerve 3 palsy, which places the lesion in the midbrain, contralateral ataxia without a significant tremor, which would suggest superior cerebellar peduncle rather than red nucleus involvement, which is what contributes to Broad syndrome. Then we move on to syndromes affecting the pons. So first one we're looking at is Millard-Gobler syndrome, which has a highly recognizable triad in the sense that it involves the facial nerve fascicles, the abducens fascicle or nucleus, and the corticospinal tract running ventrally. So this results in a consistent pattern where you have an ipsilateral facial paralysis in a complete lower motor neuron distribution. So this thing distinguishes pontine lesions from supranuclear lesions, which typically spare the upper face. Second, you're going to have an ipsilateral abducens palsy, reflecting involvement of the sixth fascicle or the nucleus itself. If the nucleus is affected, the patient will also have impaired ipsilateral gaze, but in pure fascicular lesions, that deficit is isolated to abduction alone. Third, your contralateral hemiparesis is due to corticospinal tract involvement. And these findings, two cranial nerve palsies on the same side with contralateral limb weakness, localizes the lesion precisely to the ventral caudal pons, where 6 and 7 fibers course close to the descending motor tracts. The vascular supply is typically the paramedian perforators of the basilar artery, which supply the medial ventral pontine region. So what makes Millard-Gobler so useful clinically is the simultaneous involvement of 6 and 7. So if both are affected together, the lesion must be in the pons, and if they are accompanied by contralateral weakness, the lesion must be ventral. Next is Foveal syndrome, which is a lesion at the dorsal medial pons, specifically around the facial colliculus. So the hallmark here, or one of the key points here, is involvement of the abducens nucleus. So unlike the abducens fascicle lesions, which cause only impaired abduction, a nuclear lesion produces a horizontal gaze palsy on the side of the lesion. And this is because the abducens nerve is the horizontal gaze center. It drives both the ipsilateral lateral rectus and through the MLF, the contralateral medial rectus. And damage to the PPRF produces a similar horizontal gaze palsy, but typically with preserved abduction via vestibular stimulation. When both the PPRF and the nucleus are involved, gaze toward the lesion is completely absent. So ipsilateral facial paralysis also occurs because the facial nerve fibers loop around the abducens nucleus. So this loop forms the facial colliculus, and its vulnerability to dorsal pontine lesions makes facial weakness a reliable cue to foveal syndrome localization. If the lesion extends medially enough to involve the corticospinal tract, contralateral hemiparesis may be present, though it's not always obligatory in defining it. When the MLF is included, the patient may also demonstrate internuclear ophthalmoplegia, producing a complex but still localizable ocular motor pattern. And here, the vascular supply would be via the paramedian perforators of the basilar artery that supply this dorsal medial pontine area. Again, localization principle or the pattern would be a horizontal gaze palsy, ipsilateral lower motor neuron facial weakness with or without a contralateral weakness. And this will localize it to the dorsal pontine tegmentum at the level of the facial colliculus. Next, moving on to the locked-in syndrome. It's caused by a lesion at the level of the ventral pons that selectively destroys the descending motor pathways while sparing the reticular activating system and ocular motor centers involved in vertical gaze. The key anatomical structures that are affected here would be your corticospinal tracts and your corticobulbar tracts. So your corticospinal tracts will produce a quadriplegia, and your corticobulbar tracts will produce complete loss of facial, oropharyngeal, and tongue movement, resulting in something called anarthria. Importantly, the lesion will spare the dorsal tegmentum, including the reticular formation, so your consciousness will be preserved. It also spares the vertical gaze centers located in the midbrain, allowing the patient to communicate through vertical eye movements and blinking. Because a patient with this is awake and cognitively intact, but unable to move or speak, the syndrome can produce a striking dissociation between preserved awareness and complete motor paralysis. And the most common cause is a basilar artery thrombosis, which compromises the ventral pontine blood supply. And other causes of this can include a pontine hemorrhage, central pontine myelinolysis, and demyelinating lesions, though these are less frequent. So again, clinically, to diagnose it, you'll have a preserved consciousness, preserved vertical eye movements, but complete loss of voluntary limb and bulbar movements. And this will localize the lesion to the ventral pons. Next, moving on to the medulla, the syndromes of the medulla, there's lateral and medial medullary syndrome. So in lateral medullary syndrome, the lesion involves nuclei and tracts of the dorsolateral medulla, leading to a multi-system pattern. So first, you have involvement of the nucleus ambiguus, which produces hallmark reflexes of dysphagia, dysphonia, as well as a diminished gag reflex, which is important because the nucleus ambiguus deficits do not occur in lateral pontine syndrome. So this will immediately localize it to the lesion of the medulla. Secondly, the spinal trigeminal nucleus is affected, causing ipsilateral facial loss of pain and temperature. And second, the spinal trigeminal nucleus is affected, causing ipsilateral facial loss of pain and temperature. When paired with contralateral body pain and temperature loss from the spinal thalamic tract, this will result in a classic crossed sensory pattern. Third, you'll have involvement of the vestibular nuclei, which will produce a vertigo, nystagmus, and imbalance, which can be quite severe early on. And fourth, disruption of descending sympathetic fibers causes an ipsilateral horner syndrome, ptosis, meiosis, and anhidrosis. And fifth, the inferior cerebellar peduncle leads to ipsilateral limb ataxia, reflecting disruption of the cerebellar afferents. Lesions can also involve autonomic structures such as the nucleus of the solitary tract, which affects taste and cardiovascular reflexes. And the most common vascular supply involved here would be your pica, your posterior inferior cerebellar artery, though vertebral artery occlusion can produce a similar pattern. So again, what can be used to localize here? Nucleus ambiguous dysfunction, a cross-sensory loss, and an ipsilateral Horner syndrome. Then we move to medial medullary syndrome. The first component here is a contralateral hemiparesis, which reflects involvement of the corticospinal tract, which lies anteromedially as it forms the pyramids. The second is the contralateral loss of vibration and proprioception from involvement of the medial lemniscus. And because the lemniscal fibers rotate as they ascend, this deficit affects the contralateral body with preserved facial sensation. The third component is the key localizer here, which is ipsilateral tongue weakness due to involvement of the hypoglossal nucleus or its exiting fascicles. On protrusion, the tongue will deviate towards the sided lesion. This will distinguish your medial medullary pathology from cortical causes of dysarthria and from your lateral medullary lesions, which will spare your hypoglossal system. Here, the vascular supply is typically the anterior spinal artery, which perfuses the medial medullary territory. And clinically, the combination of your contralateral hemiparesis, your contralateral proprioceptive loss, and also your ipsilateral tongue deviation will localize the lesion definitively to the medial medulla. So now that we've talked about the different sort of syndromes, brainstem syndromes, I just wanted to touch briefly on the surgical corridors around the brainstem. So when you're operating around it, the choice of the corridor is dictated by which surface of the brainstem needs to be exposed, as well as the surrounding vascular relationships. So for midline suboccipital approaches, that can give you access to the dorsal medulla and the fourth ventricle. The paramedian suboccipital corridor, including a cerebellomedullary fissure approach, provides a more direct path to your tonsillomedullary region without need for cerebellar retraction. If you wanted more anterior exposure, the far lateral or transcondylar approach allows access to the ventrolateral medulla, including pica aneurysms, lower cranial nerve schwannomas, and foramen magnum meningiomas. Lateral approaches, like retrosigmoid, provides access to the cerebellopontine angle and the lateral pons and medulla. Translabyrinth approaches is reserved for cases where you have hearing preservation is not possible or it's not required. For the midbrain, subtemporal and anterior petrosal approaches allow exposure to the anterolateral midbrain, and the orbitozygomatic approach offers a more superior and anterior trajectory towards the interpeduncular fossa and ventral midbrain. Finally, you have your supracerebellar infratentorial approach, which provides access to the pineal region, your dorsal midbrain and tectal plate with minimal brain retraction required. And again, the overarching principle here would just be to approach targets with the goal of trying to get to a specific surface of the brainstem. depending on the lesion location and its relationship to major vessels as well. So the brainstem is also vulnerable to a variety of vascular pathologies. So cavernous malformations are common within the pons and often present with recurrent or stepwise neurological deficits due to repeated microhemorrhages. The key imaging hallmark for them would be a mixed signal popcorn core with a hemosiderin rim on susceptibility sequences. Then you have your vertebral basilar aneurysms, which can arise at the basilar tip, your superior cerebellar artery, your pica or ICA origins. And depending on the location, these aneurysms can compress cranial nerves, particularly cranial nerve 3 at the basilar apex, or distort adjacent cerebellar peduncles and brainstem surfaces. You have vertebral basilar strokes, which fall into predictable patterns because of the penetrating branch organization, and paramedian branches supply the medial structures, which can produce medial syndromes with corticospinal and lemniscal involvement. You also have direct hemorrhages, which represent secondary brainstem hemorrhage due to downward displacement of the brainstem in a setting of raised intracranial pressure. And that can indicate severe, often irreversible herniation and carry poor prognosis. So I also wanted to touch on brainstem and herniation patterns. So one, uncal herniation or lateral transtentorial herniation that results from displacement of the medial temporal lobe beneath the tentorium. The earliest sign is typically compression of cranial nerve 3, causing an ipsilateral fixed dilated pupil due to any parasympathetic fiber involvement. As the uncal process will progress, the midbrain is compressed, and that can produce a contralateral hemiparesis. In some cases, when the cerebral peduncle on the opposite side is compressed against the tentorium, patients can develop an ipsilateral weakness, which is known as Finahan's notch phenomenon. Early consciousness changes reflect pressure on the midbrain reticular activating system too. Then you have central herniation or downward transtentorial herniation, which begins with diencephalic compression, and that will progress caudally. Initially, pupils are small but reactive. As the pressure increases, they become mid-position and non-reactive, and breathing patterns will deteriorate. So you can get Cheyne-Stokes, then hyperventilation, and then apnea. And motor posturing progresses from decorticate to decerebrates as midbrain and pontine structures are sequentially compromised. Then there's tonsillar herniation, which occurs when the cerebellar tonsils descend through the foramen magnum and compress the medulla. And this will produce irregular respirations, cardiovascular instability, and eventually cardiovascular respiratory arrest if not reversed. And direct hemorrhages, as we had mentioned previously. And this here is just basically showing a couple of the brainstem herniation patterns, such as the tonsillar or downward herniation, uncal transtentorial, as well as central tentorial herniation. Just a diagrammatic representation of that. So just to summarize, the functional anatomy of the brainstem is deeply structured and highly predictable, and the ventral tegmental dorsal organization repeats throughout the midbrain pons and medulla, giving each axial section a consistent pattern. Cranial nerve nuclei are arranged in longitudinal columns with motor nuclei medial and sensory nuclei lateral, and understanding these relationships allow for rapid localization of cranial nerve deficits. The major ascending and descending pathways maintain fixed positions, medial for corticospinal and lemniscal systems, and lateral for spinal thalamic and cerebellar pathways. And the combination of these positional relationships produce the classic medial and lateral brainstem syndromes. Vascular territories mirror this organization, so with paramedian branches supplying the medial structures and circumferential branches supplying the lateral territories. And that's why brainstem pathology produces distinct and recognizable clinical patterns. From a neurosurgical standpoint, safe entry zones and operative corridors and approach selection are all grounded in this sort of functional map. So with that brings me to the end of this presentation. These are my references, and thank you.